To start with this session, I'd like to invite Dr. Pankaj Goyal, who is a renowned intervention radiologist from Bhopal. Sir, please come and start your session, please.
I'll be giving a short talk on role of intervention radiology in management of complication of pancreatitis. It's basically a case-based review. Approximately 20% of patients with acute pancreatitis will ultimately develop complications that will require interventions. Now, complications can be either vascular complications or non-vascular complications. Non-vascular complications like we get collections, bowel complications, and pancreatic fistulas. In vascular complications, the most complications that we get are peripheral arterial or venous pseudoaneurysms, venous thrombosis, and rarely we get arteriovenous malformation. Now, coming to non-vascular complications, the most commonest complications are the collections, where the role of an intervention radiologist is to drain these complications, these collections, whether it can be CT guided or ultrasound guided. Here in this case, we can see that this patient has a peripancreatic large collection which has been drained by a pigtail. Now, this is another patient where this patient has a left retroperitoneal collection which is again drained by a pigtail catheter. Now, this is another patient where we can see this patient has bilateral retroperitoneal large collections with multiple air foci within it, suggestive of basically infected collection. We had put two Malicot catheters on both sides in the retroperitoneum in this patient. This was not CT guided. Now, this is another patient with a large peripancreatic collection. Patient had a fever and sepsis, so we had to put a drain. This drain is, if you see this drain, we had put this drain posterior to the descending colon. Basically, this is a retroperitoneal drain, and if the patient condition doesn't improve, if the patient further deteriorates, this tract can be used for video endoscopy assisted necrosectomy, or even this tract can be used for laparoscopy assisted necrosectomy as well. Now, coming to vascular complication, we will see the first case. We have a young male with pancreatitis. Basically, he came to us with the upper GI bleed. Endoscopy was done. On endoscopy, we could see that there was a bleed from malar papilla, and CT was done. CT showed a tiny aneurysm from the gastroduodenal artery. This gastroduodenal artery was irregular. We could see a cyst here with the high density contents, and pancreas were all calcified. Basically, this is a case of chronic pancreatitis with a cyst and bleeding from the minor papilla. We took this patient for angioembolization. This is basically a cine loop, which we can see that this is a catheter, microcatheter. Microcatheter has entered the aneurysm, and by accident we have entered the this cyst, which was bleeding from the minor papilla, and subsequently we embolized this aneurysm with the help of coils and PV particles. This is how we place the coil through the microcatheter. What we have done here, this is basically the aneurysm. We have put the coils distal to the aneurysm and proximal to the aneurysm, so that this aneurysm doesn't fill from both the sides. Subsequently, we have to place multiple coils in the vessel. And this is the final celiac DSA showing there is completely occlusion of the aneurysm. This is a hepatic artery showing patent. Now, coming to case 2. Case 2 is a young male with pancreatitis. He had a pain in the left hypochondriac region with fall in hemoglobin. CCT was done. CCT shows a large pseudoaneurysm in one of the branches of distal splenic artery, and surrounded by hematoma. We can say that surrounding the aneurysm there is a hematoma, and there is a collection in the perisplenic space as well. We took this patient up for angioembolization. This is basically a splenic artery aneurysm DSA. We can see that beautifully the aneurysm is filling, and the surrounding this parenchyma is a splenic parenchyma. This is a still image showing the pseudoaneurysm here and the splenic parenchyma here. We tried to cannulate the vessel, which was specifically leading into aneurysm, but we were not able to do that because of tortuous anatomy. So what we did is to embolize the distal feeder, we embolized the artery from here with the help of PV particles, so that the aneurysm got embolized. Along with the aneurysm, some of the lower pole of the spleen also got embolized in this case. This is how we embolize the distal feeder. Now, to embolize the proximal feeder, we had placed the coil in the proximal feeding artery, and this is the aneurysm which is showing there is completely stasis. There is no flow of blood into the aneurysm. And this is the final picture of the post-embolization, there is completely exclusion of aneurysm from the circulation. Now coming to case 3. Case 3, we have a middle-aged male with pancreatitis, same acute deterioration in clinical condition and fall in hemoglobin. CCT was ordered. CCT showed a large aneurysm in the mesocolon. We can see there is a large aneurysm in the mesocolon which was bleeding and causing fall in hemoglobin. We took this patient up again for embolization. What we could see was, we could see that there is a small aneurysm which is originating from one of the mesocolic branches of the SMA. Subsequently, this is the still image showing the pseudoaneurysm here from the mesocolic branch. We embolized it with the help of PV particles, and finally there is completely aneurysm is occluded. Post-embolization, patient's hemoglobin had stabilized. Now coming to the final case, this is the most interesting case which we had done it recently. Basically, it's an elderly male with acute pancreatitis. He had a large pseudocyst in the lesser sac region, fever with sepsis was present, and he had a deteriorating vitals. CCT was done. CCT showed a pancreatitis with a large collection in the lesser sac region. This is the stomach. Stomach is pushed anteriorly. There is a collection behind the stomach in the lesser sac region. So, US guided cystogastrostomy was done and a metallic stent was placed in this case. We can see beautifully placed metallic stent. One end is in the stomach, other end is in the cyst, with the contents of the cyst being drained into the stomach. Basically, this is a cystogastrostomy stent. Initially, patient improved. After a few days, again the patient started to deteriorate. Again, the patient was taken up for scopy with the idea that the stent might have occluded, and they wanted to reopen the stent so that the contents may get evacuated from the cyst. This is the picture which was seen on endoscopy. Basically, what we see here is the scope has been passed through the stent into the cyst. This is the view inside the cyst. We can see that there is an active spurt bleeder which is seen, which is bleeding into the cyst. We can see here this is the mesh of the stent. So there was active bleeder which was bleeding into the cyst, and ultimately it was bleeding into the stomach. We did a CT angiography of this patient. On CT angiography, we can see the stent here. Basically, this is a celiac artery, and this is a left gastric artery. Left gastric artery is showing a tiny pseudoaneurysm here near to the lower margin of the stent. One more finding that we could see in this case was the inferior pancreatic artery was dilated, it was hypertrophied, and it was giving multiple small branches to the cyst wall. So we took this patient up for embolization. This is the first seen image. So unfortunately, while doing this procedure, while we were trying to cannulate the left gastric artery, we were not able to cannulate. This patient had a plaque at the origin of the left gastric artery. So what we did is we ended up rupturing that plaque and creating a dissection, arterial dissection. Now we were stuck. Despite multiple attempts, we were not able to cannulate the lumen of the artery. So what we did is we extended this aneurysm further, we extended the dissection further, and we dissected the artery further up to the level of the pseudoaneurysm here. So what we did is we dissected the artery furthermore to reach up to the level of the pseudoaneurysm, and we filled this false lumen with PV particles and gel foam. Subsequently, the true lumen was also occluded. Then in the next step, we cannulated the inferior pancreatic artery. We can see this is the inferior pancreatic artery. It is dilated, tortuous, and we can see multiple tiny collaterals are being given to the cyst cavity, and one of the collateral is being supplied to the bleeder site as well. Subsequently, we embolized this artery, and with this is post-embolization. We can see there is complete stasis of blood in the artery. Post-embolization, hemoglobin stabilized. After a few weeks, repeat endoscopy was done, and the metal stent was removed, and the patient is doing quite well. Now, to conclude my talk, diagnosis and management of complicated pancreatitis is most effective when implemented in multidisciplinary team manner, including diagnostic and intervention radiologist, advanced endoscopist, pancreatic surgeons, specialists in infectious disease, critical care specialist, and nutritionist. Thank you.
Thank you, Pankaj, for such an excellent talk and wonderful cases. Any questions on the house? So Pankaj, whenever you do the percutaneous drainage of the pseudocyst and pancreatic collections, when we look for a safe window that is defined as skin to target, what are the organs which you can traverse safely? Suppose you might have to drain a transhepatic drain. I think it will be useful for us. Is it safe to go over transhepatic or a transgastric PCD?
Yeah, we have done few cases where we have even drained the collections transhepatic. We have drained the collection transgastric also. Transgastric is quite safe. That's what I felt. We can do directly also, like transhepatic or transgastric. The most important thing is there should be indication of drainage. First of all, we should not drain the pancreatic collection just because there is a collection. There has to have a solid indication that this collection has to be drained. The patient should be in sepsis. In many cases, we can even put a needle into the collection and we can aspirate and see whether it is actually infected collection or not. So because pancreatitis patient will be having something called as systemic inflammatory response syndrome. They will be showing fever without any sepsis also. So we need to have evidence that this cyst has to be drained. If it has to be drained, it has to be drained. Doesn't matter whether it's a transhepatic or transgastric or retroperitoneal approach.
Dr. Pankaj, the third case which you saw, the last case,
Yes,
which was stent was placed and the patient was bleeding into the stent. Was the endoscopy done first or was the CT done first?
Endoscopy was done first. Endoscopy showed there was a bleeder in the cyst cavity. There was a bleeder in this. But what they did was they had put the scope through the stent into the cyst, and there was a bleeder into the cyst.
I think then it was a very wrong thing to subject that patient for a CT scan.
Exactly. It was.
The next thing that should have been done was you should have taken up the patient for.
Exactly. We did that same
procedure.
thing. We did the same thing. We took up the patient for embolization. As soon as we saw the bleed, we embolized the left gastric artery at that point of time.
Just to clarify, this patient had after putting the cystogastristomy, he underwent 2 sessions of the DEN actually. After that, in the ward, he presented one day with the Malina. So then we took for the endoscopy. So at the time we tried to, the time we saw the bleeder, so then we called for the radiological intervention.
The only thing which I want to assess is that if such a bleeder is found on endoscopy
We
or
can go directly and
during
embolize it.
anything,
We did that
we should
same
not
thing.
waste any time in getting a CT scan done. The next thing that is empirical and that the way it was presented was it looked like he bled, then a CT was done and then an intervention.
He was so sick, his
Yeah.
BP on endoscopy table was 60 systolic, and
Yeah.
we just at the adjacent room we shifted for angio. I think that was not conveyed.
Actually, we had embolized this patient twice. When this bleeding was there, we embolized once, the patient stabilized. Then this patient had a rebleed after 15 days. That is the time when we did a CT scan.
Another question is for you. Actually, now, like when we have collection, necrotic collections are there in the retroperitoneum. So, have you a discussion routinely with the surgeons? Like because sometimes we do necrosectomies through the
Drain side.
pigtail catheter route.
Yeah, we can
or the
dilate that.
manicoid route.
Yeah.
So we need to have a shortest route from the retroperitoneum from
Exactly.
the posterior
Cyst.
wall. So have you a discussion with surgeons in planning from where can you approach which will be easier for them to remove like the new procedures like VARD have come, so that for those video assisted retroperitoneal dissections we can use that track as
Exactly. Whenever we are doing a CT guided drainage of the retroperitoneal collection, we choose the shortest possible path. We try to see that it is as straight as possible. It is as linear as possible. We don't want to go in a tortuous path, and we want to make sure that right now we are draining it, but in future if the patient doesn't improve, he might need necrosectomy.
Maybe,
So we are always prepared for that.
Right.
And for that we need to dilate the tract up to 30 French. We need to seriously dilate. We cannot just put a this drainage VATS scope, I think, below 30 French.
Right.
So we need to dilate the tract sequentially.
And another thing is when sometimes we have a bleeder from SPDA, spiropancreaduodenal, or any branch GDA, sometimes many interventional radiologists put glue particles. There are high chances of migration into the hepatic artery, and we have seen
Which
a
particles?
case-
Glue particles.
Yeah, the embolization particle which you
See, the
use,
thing
sometimes
is,
they migrate to
exactly.
the hepatic artery and they cause partial ischemia of the liver
Exactly.
as
Exactly.
well.
That is
Yeah.
why we are not using glue.
Yeah.
We know that glue, it is very difficult to control glue basically.
Yes.
Controlling glue is an art. It is not everybody's cup of cake. So the safe option here is coils.
Coils.
If you are able to go distal to the neck of the aneurysm, put a coil, come proximal, put a coil, that's it. And the next safe option that we have found is PVA particles and gel foam together work quite well, like in this case. We have never used glue in this in embolization procedures. It's very difficult to basically control glue, and once the catheter might get stuck, the glue might fly away somewhere else, so we might end up embolizing somewhere where we don't want to embolize. That is a problem with the glue.
Thank you.
I just beg to differ on that. I mean, you are saying glue particles. So glue is a liquid embolic agent. Particles, what we talk about is the PVA particles. So these two things are different. So if you inject a PVA particles, they have high chances of migrating to the distal parenchymal bed and cause the organ injury.
Right.
However, glue is something which you can control. You can allow glue to coagulate just at the level of the catheter by titrating the quantity of glue.
Right.
So if you inject a 50% glue, it will not go anywhere, just occlude the artery itself. If you inject a 20% glue, like we do in AVM, it will migrate. So in cases, the preferable solution is to place the metallic coils because you have better control and you want a proximal embolization. In many cases, as the Pankaj has already elaborated, you are not able to cross to the opposite side of the aneurysm. Then you can anyway inject glue with a higher concentration, which will not go into the parenchymal bed, just block the artery. So PVA particle is something you might avoid, but glue is safe. And now glue has a lot of role in GI embolization. It is a very upcoming thing.
Yeah, that's right.
So if you see the Western literature now, they are shifting from even coils to the glue embolization. So which is because it is very effective, it is cheap, and if you can control the glue, it's nothing like that. Another question, Pankaj, I think we are late, but do you have any experience of interventions in portal venous thrombosis in such cases, and when do you take such patients for intervention beyond the routine conservative management?
We have done few cases of portal vein thrombosis, but they were not basically related to pancreatitis. They were because of some other causes. What we had done is we had directly punctured the portal vein, we have put a catheter into the portal vein and did thrombolysis along with thromboaspiration. So a few of the patients have improved as well, but one of our patients didn't improve much. He ultimately had to undergo surgery for bowel resection. So I don't have much of experience on portal vein thrombolysis. So we try to avoid that procedure as much as possible.
Thank you so much. Any questions?
Recently, like TIPS is also tried for portal vein thrombosis. We can put a TIPS stent, and we can aspirate the thrombus and do thrombolysis from the TIPS thing. That we have not done in our institute till now. Maybe in future.
Thank you so much, Pankaj, for a wonderful lecture.
Thank you.